This is Lecture 13, High-Yield Pediatric Emergencies. Children compensate until they crash. The ED job is pattern recognition through the Pediatric Assessment Triangle, weight-based dosing, age-stratified workups, and recognizing that pediatric vital sign abnormalities have different meaning. Toxic appearance overrides protocols. The objectives are these. First, apply the Pediatric Assessment Triangle. Second, manage pediatric fever with age-stratified evaluation. Third, recognize and treat pediatric sepsis with weight-based fluids and pressors. Fourth, manage pediatric respiratory distress and the failing airway. Fifth, differentiate Croup, Epiglottitis, and foreign body. Sixth, manage pediatric dehydration and DKA. Seventh, recognize non-accidental trauma. And eighth, ensure pediatric medication safety with weight-based dosing. The pediatric ED mindset is that children compensate until they suddenly crash. Vital sign normals are age-dependent. Hypotension is a late finding. Tachycardia, altered mental status, poor perfusion, and work of breathing are earlier warnings. Use kilograms only for medication and fluid dosing. Hypoglycemia and hypoxia are fast killers. Toxic appearance overrides the pathway, and always keep non-accidental trauma on the differential. 2 pediatric-only diagnoses to keep ready. Kawasaki disease, fever 5 days or more plus 4 of the 5 crash and burn criteria, with coronary aneurysm risk, and the answer is IVIG plus aspirin. And hemolytic uremic syndrome. The triad is microangiopathic anemia, thrombocytopenia, and acute kidney injury, classically post-Shiga toxin E. coli. The classic distractor is giving antibiotics for E. coli 0157H7, which worsens HUS. Do not. The Pediatric Assessment Triangle is a doorway tool. Appearance, work of breathing, and circulation to the skin. Appearance includes tone, interactiveness, consolability, look or gaze, and speech or cry. Work of breathing includes abnormal sounds, stridor, wheeze, grunting, abnormal positioning, tripod, retractions, and nasal flaring. Circulation to skin includes pallor, mottling, and cyanosis. Any abnormal arm triggers immediate action. The triangle is completed in seconds without touching the patient. If it is abnormal, act before the full history is complete. Boards. ITE buzzword. Compensated shock means the blood pressure is still normal while the heart rate climbs. Normal blood pressure is the last thing to drop in a child. If you wait for hypotension, you are late. Pediatric fever evaluation is age dependent. Neonates 0 to 28 days. High risk for serious bacterial infection. Full evaluation. Blood culture, urine culture, lumbar puncture, and admission for empiric antibiotics regardless of appearance. Infants 29 to 60 days. Structured pathways, such as step-by-step, Rochester, or PCARN, stratify risk based on appearance, age, urinalysis, blood markers, and procalcitonin where available. Low-risk infants in this group may avoid lumbar puncture and may be observed. Infants 61 to 90 days. Less aggressive workup, but still careful. Older infants and toddlers, appearance, immunization status, source identification, and urine risk drive the evaluation. Toxic appearance overrides the pathway at any age. Most common bacterial pathogens by age. Neonate is group B strep, E. coli, and listeria, so empiric coverage is ampicillin plus ceftriaxone or gentamicin. Older infants shift to S. pneumonia and H. influenzae. The HSV neonate is the classic ITE trap. Vesicles, seizures, or a sepsis-like picture in the first weeks of life means add acyclovir empirically. Pediatric sepsis recognition is clinical. Tachycardia, poor perfusion, delayed capillary refill greater than 2 seconds, weak pulses, cool extremities, altered mental status, and respiratory distress are key features. Compared to age-specific normal vital signs, treatment includes early antibiotics within 1 hour of recognition, within 30 minutes for septic shock per recent guidelines, isotonic crystalloid boluses of 10 to 20 milliliters per kilogram with frequent reassessment, repeated boluses is tolerated up to 40 to 60 milliliters per kilogram in the first hour, and vasopressors when fluid refractory. Epinephrine 0.1 micrograms per kilogram per minute, or norepinephrine for warm shock. The board concept is that pediatric sepsis is treated aggressively, but with frequent reassessment for fluid overload. Pediatric respiratory distress is the most common emergency pattern. Work of breathing typically worsens before oxygen saturation falls. Stridor, retractions, nasal flaring, accessory muscle use, head bobbing, and grunting are key signs. Fatigue is a late danger sign. A previously distressed child who suddenly looks calm but is not actually breathing better is in trouble. Tone change, decreased crying, and altered mental status mean impending failure. Initial management includes oxygen, suction, positioning, and disease-specific therapy. The board concept is that pediatric respiratory failure looks different from adult. Fatigue and decreased work of breathing in a sick child is bad news, not improvement. Croup, epiglottitis, and foreign body have different management. Croup, viral laryngotracheobronchitis, barking cough, inspiratory stridor, hoarseness, mild fever. Treatment is dexamethasone 0.6 mg per kilogram orally, max 16 mg, nebulized epinephrine for moderate to severe, stridor at rest, and observation. Epiglottitis, rapid onset high fever, drooling, dysphagia, tripod position, toxic appearance, often in unimmunized children. Do not agitate. Keep with caregiver. Prepare for controlled airway management in the OR with anesthesia and ENT. Antibiotics after airway secured. Foreign body aspiration, sudden choking, coughing, stridor, or focal wheezing. Encourage coughing in a stable child. Back blows and chest thrusts for infants. Heimlich for children over 1 year. Endoscopy for confirmed or persistent obstruction. The board concept is to not agitate a child with a threatened upper airway. ITE buzzwords. Croup is the steeple sign on AP neck X-ray. Epiglottitis is the thumbprint sign on lateral neck. Bacterial tracheitis is the mimic. Stridor plus high fever plus toxic appearance, often following a viral URI, and it does not respond to nebulized epinephrine. Foreign body aspiration in a toddler classically presents with sudden choking on peanuts or coins, and the chest film shows ball valve hyperinflation on the affected side. Bronchiolitis is viral lower respiratory illness in infants under 2 years, most commonly RSV. Management is supportive, nasal suction, hydration, oxygen for hypoxia, and high-flow nasal cannula for moderate to severe distress. Bronchodilators and steroids do not routinely help bronchiolitis. Hypertonic saline nebs have mixed evidence. Admit for hypoxia, dehydration, fatigue, or apnea in young infants. Pediatric asthma is treated like adult asthma in many respects. Albuterol nebulization, ipratropium for severe, systemic steroids, dexamethasone single dose or prednisolone course, magnesium for severe. Silent chest or fatigue is impending failure. The board trap is treating bronchiolitis like asthma in a child under 2. The classic distractor on the exam is albuterol, steroids, or antibiotics for routine bronchiolitis. None of them help. Pick supportive care. Pediatric dehydration management is severity-based. Mild dehydration, oral rehydration with small frequent volumes of an electrolyte solution. Moderate oral rehydration trial, intravenous if failing. Severe or shock, isotonic crystalloid boluses 10 to 20 milliliters per kilogram repeated with reassessment. Diabetic ketoacidosis in children requires a specific protocol because of cerebral edema risk. Fluid resuscitation should be cautious, often with smaller boluses, 10 milliliters per kilogram, and slower deficit correction over 24 to 48 hours. Avoid rapid serum sodium changes. Use insulin infusion without a bolus. The board concept is that pediatric DKA is different from adult DKA, and cerebral edema risk drives more conservative fluid management. 2 surgical mimics of dehydration to no cold, pyloric stenosis, age 2 to 8 weeks, projectile non-bilious vomiting, palpable olive with hypokalemic metabolic alkalosis on the lab panel, and bilious vomiting in a neonate, which is malrotation with midgut volvulus until proven otherwise. Upper GI series is the next step. Intussusception is the 6-month to 3-year-old with the sausage-shaped mass and target sign on ultrasound. Current jelly stool is a late finding, and air enema is the next step. NEC, necrotizing enterocolitis, is the premature infant with abdominal distension and bloody stool, and pneumatosis intestinalis on the abdominal film is the buzzword. Pediatric trauma combines physiology and anatomy. Children compensate, hypotension is late. Tachycardia, mental status, and perfusion are earlier clues. Anatomic differences include larger head-to-body ratio, increasing head injury risk, more pliable bones leading to internal injury without fracture, smaller airway, larger spleen and liver relative to ribs, and immature cervical spine ligaments. Pediatric trauma resuscitation requires weight-based dosing, blood at 10 milliliters per kilogram boluses for hemorrhagic shock, and aggressive temperature management. Non-accidental trauma must be considered when the story does not match the injury, the developmental stage does not match, there are multiple injuries of different ages, or the caregiver story is inconsistent. The board trap is missing non-accidental trauma. Pediatric medication safety prevents the most common ED errors. Use kilograms only. Never pounds for medication or fluid dosing. Verify weight at presentation. Use a length-based resuscitation tape, the Braslow tape, for unknown weight. No dose caps for adult equivalent doses. Pay special attention to epinephrine concentrations. Cardiac arrest is the 1 to 10,000 strength, 0.1 milligrams per milliliter, at 0.01 milligrams per kilogram intravenously. Anaphylaxis is 1 to 1,000, 1 milligram per milliliter, intramuscularly at the same per kilo dose, max 0.5 milligrams. Sedation, opioid, and insulin doses are common error points. Closed-loop communication, independent double-check for high-risk medications, and family involvement reduce harm. The board concept is that pediatric medication errors are common and preventable. Non-accidental trauma must be on the differential for every pediatric injury that does not fit. Red flags include injury inconsistent with history, developmental stage incompatible with mechanism, delayed presentation, multiple injuries at different stages of healing, patterned bruises, loop, hand, slap marks, bruises on infants who are not yet cruising, immersion burns, sock or glove distribution, shaking injury, retinal hemorrhages, subdural hematoma, rib fractures, and metaphyseal corner fractures or posterior rib fractures, pathomnemonic for abuse. Mandatory reporting to Child Protective Services and law enforcement is required. Skeletal survey for children under 2 with suspected abuse. Ophthalmologic exam for retinal hemorrhages. Document thoroughly. The board concept is that EM physicians are mandated reporters, and missing non-accidental trauma can be fatal. ITE sentinel injury buzzwords to memorize: a bruise on a non-cruising infant, a torn frenulum, and an ear bruise, a spiral fracture in a non-ambulatory child, posterior rib fractures, and the metaphyseal corner or bucket handle fracture are the radiographic giveaways. Retinal hemorrhages point to abusive head trauma. The pediatric board traps are predictable. Normal blood pressure falsely reassuring you in a child in compensated shock. Treating bronchiolitis like asthma in a child under 2. Agitating the child with suspected epiglottitis. Missing urinary tract infection in a febrile infant. Using adult doses without weight conversion. Discharging a febrile neonate based on well appearance. Missing non-accidental trauma. Underestimating dehydration in a child with persistent vomiting. And rapid fluid correction in pediatric DKA causing cerebral edema. A normal blood pressure is the wrong reassurance in a sick child. Case 1. A 21-day-old has a temperature of 38.1 degrees Celsius at home, but appears well in the ED with good tone and feeding. Age drives risk in neonates. Despite the well appearance, this infant requires full serious bacterial infection evaluation, blood culture, urine culture, lumbar puncture, complete blood count, basic metabolic panel, and empiric antibiotics, ampicillin plus cefotaxime or ceftriaxone considering listeria coverage. Admission is required. The board trap is discharging because the infant looks well. Neonates compensate. Case 2. A 4-month-old with 3 days of bronchiolitis now has fewer retractions but is less active. Respiratory rate has decreased. End-tidal carbon dioxide is rising. This is not improvement. This is fatigue, an impending respiratory failure pattern in pediatrics. Escalate respiratory support. High-flow nasal cannula or non-invasive ventilation. Prepare for intubation if failing. ICU admission. The board trap is interpreting decreased work of breathing as recovery in a sick infant. Question 1. A 21-day-old has fever at home. The infant appears well in the ED. What is the disposition? The answer is full serious bacterial infection evaluation and admission per neonatal fever pathway, empiric antibiotics. The board trap is discharging because the infant looks well. Neonates compensate. Question 2. A toddler presents with barky cough and stridor at rest. What is the treatment? The answer is dexamethasone 0.6 milligrams per kilogram orally and nebulized racemic epinephrine. The board trap is giving antibiotics for what is a viral illness. Question 3. A child weighing 10 kilograms is in septic shock. What is the initial fluid bolus? The answer is isotonic crystalloid 20 milliliters per kilogram, which is 200 milliliters, with reassessment after each bolus. The board trap is using a fixed adult bolus without weight-based calculation. The final takeaways are these. Children compensate, then crash. The pediatric assessment triangle is the doorway tool. Use kilograms only. Hypotension is a late sign. Tachycardia, work of breathing, mental status, and perfusion are earlier. Neonatal fever is full evaluation and admission regardless of appearance. Pediatric sepsis, early antibiotics, weight-based boluses with reassessment, vasopressors when fluid refractory. Do not agitate a child with a threatened upper airway. Bronchiolitis is supportive. Croup gets steroids and racemic epinephrine for stridor at rest. Pediatric DKA needs cautious fluids because of cerebral edema risk. Use length-based resuscitation tape for unknown weights. Always consider non-accidental trauma. Toxic appearance overrides the pathway. Well, appearance is the wrong reason to discharge a febrile neonate. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the American Academy of Pediatrics Clinical Practice Guidelines, the Pediatric Advanced Life Support, PALS, Provider Manual, the European Resuscitation Council Pediatric Guidelines, the Step-by-Step Approach to Febrile Young Infants, the PCARN Clinical Decision Rules for Head Injury and Abdominal Trauma, and the American Diabetes Association Pediatric DKA Management Guidelines, local pediatric protocols, Child Protective Services reporting procedures, and the Broslow Length-Based Resuscitation Tape Guide, Site-Specific Care.